I think so. It is 6:05 to 6:05. Can we start over?
Yes, ma'am. Are we good to go now, ma'am?
Okay.
Okay.
So here's a big welcome, warm welcome, and good evening to all the participants and the speaker, chairperson, moderators, and the team, ClearNet, Dr. Chaturvedi Cancer Hospital, and the Oncology Integrated Society participants. It's a proud privilege to be with you all and hold this series of webinars from our part. And today is a very burning topic about the stereotactic in treating the brain cancers. As you all know, the brain cancer is, according to the IARC registries, report that there are over 28,000 cases of brain tumors in India each year, and more than 24,000 people, they are dying due to this cancer annually. In US, an estimate of 79,340 adults of age over 40 plus will be diagnosed with this cancer this year. They say it will be diagnosed. Most commonly being the meningiomas and the glioblastomas. There are various types of radiotherapy techniques, and there are many types of disciplinaries in treating brain cancers. And among the, today we have chosen the topic of radiation. So we'll tell you, enumerate only the various varieties, just like conventional radiotherapy, proton therapy, IGRT, stereotactic radiotherapy, linac, gamma knife, and 3D radiotherapy. For this, to bring this to light and enlighten all of us, we have a great speaker and a great chairperson, Dr. A.K. Chaturvedi, who has an experience of 40 years, more than that, and who is the owner and has the privilege to be the radiation oncologist himself. He has done his MD, he has done his MBBS and MD from MGM Medical College Indore, and after that he had various trainings abroad and in India. And he has also been past president, UPAR, and has been treating brain cancers and all sorts of cancers during these past years. But now, as the technology is developing further and further, we need to do continuous medical education, and for which we have an eminent speaker. I'll hand over the dais to Dr. A.K. Chaturvedi. Please introduce our speaker, Dr. Rashmi Shukla. Over to you. You are on mute mode.
Thank you, Dr. Deepti. And today's topic is very interesting. It's a benign and malignant brain tumors. Role of stereotactic in these tumors. Now, how to deal with these tumors? We are going to have a talk by Dr. Rashmi Shukla, consultant radiation oncologist, Max Super Specialty Hospital, Patparganj, Delhi. She's coming for the second time, as previously she spoke very well in this webinar. She has completed her DNB in radiotherapy from Mahavir Cancer Sansthan, MBBS from Behranpur Medical College, Odisha, and she is a member of different organizations, AROI, STRO, ISO, IMA, ESMO, so many organizations. And her special interest is IMRT, IGRT, IGRT with rapid ACR and VMET, SRS, TBI, and so on. So now I am inviting Dr. Rashmi Shukla for her talk. Welcome, Dr. Rashmi. Dr. Rashmi, are you there? Remote.
Sir, am I audible, sir?
Yeah, now you are audible and visible.
Shall I share my screen or you will show some video first, ma'am?
Okay, no problem, as you feel.
Ma'am, you are mute.
We all are doing the same common mistake. Yes, the girl, Ankita, where are you?
Yes, ma'am. I'm here, ma'am.
Just say a few lines about clarinet and then
Sure,
play
ma'am.
the video.
Sure, ma'am. Hello and good evening to all. I'm Ankita from Planet, the designated session assistant for a seamless experience, and Planet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Planet is very proud to be a digital partner for this event organized by Oncology Integrated Society, and topic of today's session is advanced radiation techniques in brain cancer. So I would like to play a short video. Over to you, ma'am.
Thank you. Thank you.
Now, continue with your deliberation, Dr. Rashmi.
So, very good evening to all of you. So, today I am going to talk about the role of stereotactic in benign and malignant brain lesion. So, today I am going to focus only and only indications of stereotactic, not the methods, because different centers have different machines like Varian and Electra. They have different types of accessories and all. So, in the 20 to 30 minutes, we are going to discuss what are the important indications of stereotaxis, where it actually the role comes. So let's start with this. So these are the three important words which we have to understand it very clearly. First is stereotactic radiosurgery, that is SRS. We say SBRT. No, I found so many times that the juniors or from other centers, they have written SBRT for brain. No, SBRT is only and only for extracranial lesion. So either SRS or FSRS is used for brain lesion. So stereotactic radiosurgery means whatever the dose we are giving, if we are using in single fraction, then it is SRS. But sometimes when the volumes are very, very large, so many things it's sitting on the critical structures, we have to fractionate it. But within 3 to 5 fractions, then we called as FSRS. And obviously, stereotactic radiotherapy when we are using 20, 25 fractions. So it is very, very clear that in brain lesions, when we are using stereotaxy, either it is SRS or FSRS. So stereotaxy, what it means that we have to give a very high dose of radiation with a pinpoint accuracy like a pencil beam, with completely targeted to the focus to the target area. So this is the beauty of stereotaxy. It is a double-edged sword. If we are going to miss the target or we are giving the radiation to the normal organ, then the risk of damage is much, much more. So in stereotaxy, there is more important to have the control or the target derivation or the dose control of normal organs in spite of the target. Because when we are going to miss the target, it's also not good. But if we are going to radiate the normal organ with 20 gray, 24 gray in brain, the risk of radionecrosis is very, very dangerous. So as I said that Varian, Electra, they have different accessory modes. They have different, like we have Varian, we have Exactrack with that. So that, and they have certain MRI features and with the imaging and all, So these are the different accessories used for SRS in brain lesion, or we have the brain lab, iBrain lab planning system. So these are the accessories to the planning system. So now coming to the indications. What are the indications of SRS or SRS in FSRS in brain lesion? Coming to the malignant lesion, the most common is the brain mets. So we will discuss when to give, when not to give, and what are the indications and what are the precautions we have to take, and what are the important major points. While sitting in the tumor board, you have to decide that whether to go with SRS or not to go with SRS. So in malignancy, the most commonly we have done since 5 years for the brain metastasis. This is the most commonly in per month. We are getting 5 to 7 average 10 patients for SRS or FSRS. Primary malignant brain tumors in GBM, yes, they are saying, but mostly in the recurrent setting. In the recurrent setting, we have used few patients, but surgery, yes, surgery is the first choice. But in primary GBM also they have done, but we have not done any time. Then coming to the benign lesions like EV malformation, cavernous meningiomas, trigeminal neuralgias, pituitary tumors with schwannoma, pituitary adenomas, meningiomas. In those cases, there are certain roles of stereotactic. So let's go one by one. First, in brain metastasis. So in brain mets, as we know that we are giving the whole brain radiation since very, very long time. But the most important demerit of whole brain radiation is that when we are giving the whole brain radiation after 3 to 6 months or 8 months, there is certain decline in neurocognitive function. So, in brain mets, so why we are using SRS? So the most important factors or most important advantage of SRS in brain mets to restore the neurocognitive function. We will go ahead what are the indications for that. In doing I am just touching because it's a vast topic and I just want to give a very, very take-home messages and a clear-cut one-line indication what are the advantages of that. So in brain mets, for the MRI is the most, for all the brain lesions, MRI is the important diagnostic tools, but certain features, especially for the brain mets. So for the brain mets, what we do a thin section that is less than 1 mm. We do with zero gantry. We have certain protocols of MRI so that we get very, very, very exact accuracy of MRI. Because in our CT plan, we are taking the CT scan of section less than 1 mm, that is 0.6 to 5 mm slice thickness. So we have just incorporated that MRI people also do, that is 6 to 7 mm slice thickness of MRI they are getting. But the two most important thing is that, as we know that MRI, it can detect 20 to 30% more mets than CT. Second thing is that while doing the SRS, we have to use a double contrast MRI lesion. We have seen, even we have just for few patients, we have just for incidentally and coincidence, when we have given the MRI, done the MRI for just for a follow-up for lung patients. But when we found there is certain mets and we have repeated it for doing the SRS by giving a double contrast, at least 20 to 30% volume, either new lesion or the same lesion, the volume has increased, we have found it, and literature also supports. So in MRI, double contrast volume is necessary for doing the SRS. Very good section, patient should not move during MRI. So this is the whole sole crux, and all your local control and results depend on how nice the MRI is there. Because today we are doing one FSRS for radiation patient. Patient was little bit anxious, irritated. his 3D planning, which we have done outside from MRI, we get the CD. Patient has moved on and it's not very clear. So if the patient has moved on more than 2 mm slice thickness, then your whole of the stereotaxy, the failure rate will be high. So this is about MRI for especially for the brain mix. So coming for the option of brain mix, as we know 20, 30 years back, whole brain radiation is the single modality of treatment for all the brain metastases, whether it is single, multiple. Even if I have just, while the literature, and I have just discussed with few of my seniors while they are doing PG in 99, 2003, they are saying even after the post-op metastasis brain mets lesion, they are giving whole brain radiation in 99, 2003, like that. So that the concept has changed slowly, that after doing the post-op brain metastatic lesions, we are giving only and only to the SRS as of SRS to the cavity. So we have different options, surgery, SRS, and whole brain radiation. But as I discussed earlier, that what is the benefit of whole brain radiation? Yes, it can take care of small and micro metastasis, because we have seen, like today, just now, 3 months back, we have completed one admission for SRS. But what we have missed in that patient, a very tiny, which our radiologists have failed to report, the lesion was in the brainstem pons lesion. And after 3 months, when we repeated the MRI, that lesion has increased and increased in enhancement. So this is also the fallacy sometimes, because small micro metastasis, which is missed during the reading, while doing the exact or very good of MRI level, but still we can miss it. So the benefit is it takes care of small and micro metastasis, and it will reduce the tumor recurrences. We can treat the large, small, or multiple tumors at the same time, or each tumor. But the side effect is, yes, hair loss, fatigue, headache, otitis media. This sometimes so many people miss because they include the whole bacteria while giving the radiation. These patients, even if 30-degree otitis media is there, somnolences, memory loss, radiation necrosis, leukoencephalopathy. So post whole brain radiation, this leukoencephalopathy, this is the major culprit for having the decrease in neurocognitive function. So how we decide the SRS? So these are the 3 factors, like patient, treatment, and disease. So patient, what is the age of the patient? How much he is symptomatic, his medical condition, neurological status, patient wishes, as well as how much is the extracranial burden of disease. That is the very important factor for SRS. If the patient is heavy extracranial burden, survival is less than 3 months, and I don't know what we are going to achieve with SRS, because SRS will give only and local control to that radiation area. Rest of the brain, it will not take care of that. Or we have to include the prior history of whole brain, status of systemic disease, distal mets, number of brain mets, and all. So while evaluating any patient in a tumor board, when you see any patient with a brain lesion with primary extracranial site, we have to first see. This slide is the whole crux of the take-home messages, like that. If any tumor, we normally say that 4 centimeter, 3 centimeter tumor, 3 or 4 centimeter, beyond 4 centimeter, we usually avoid SRS. But any tumor, even if it is 2.5 or 3 centimeter, but the patient is symptomatic, extensive bar septate, edema, midline shift, transtentorial herniation, we should not go for SRS, even not for whole brain. The patient is the candidate for the tumor decompression or resection of the lesion. So this is very important. Don't do SRS, never do SRS in all of these features. Otherwise, you will just add the toxicity to the patient, and sudden the herniation and everything will happen, and patient will collapse. And so that will be. Second thing, Asymptomatic, good performance status patient is very, very important because patient by making the mask also, we have using a triple layer mask for SRS. It needs 40 to 45 minutes for adjusting for CT planning, including mask preparation, as well as during treatment, because to achieve the very, very high level of conformity, we have to use multiple non-coplanar beams, and it will increase the treatment 30 to 45. Even if in true beam we are using a triple F, it is a very rapid fire rate of radiation, but in spite of that, because of non-coplanar beams, certain movements of the couch and all, it will usually take 40 to 45 minutes. And sometimes the lesion is the extreme cranial part, then the matching and everything, sometimes it doesn't match. To 1 hour minimum, we have to take free of the machine. So the patient is having an asymptomatic patient. The tumor volume, normally we decide that less than 25 cc at least should be there to having the SRS or FSRS. But if it is a biliary disease, leptomeningeal disease, multiple brain mets, and volume is exceeded, but still the life survival is not good, multiple extracranial mets are there. So in that cases, if we have to give them whole brain radiation is sufficient. Then when we decide the volume, yes, this is the volume. So whether we have to fractionate it or single fraction or multiple fraction, we have to decide according to the volume of the lesion. And we follow the MRI normally after 3 weeks of radiation. So after 3 months of radiation, we repeat an MRI follow-up with, so this is the disadvantage that in whole brain RT, we are at least sure that the new recurrences will be delayed or at least it is controlled. But in SRS or FSRS, we have just given radiation to local site. Even beyond 2 to 3 centimeters, there is still chances of recurrences which can occur anytime. That's why in small cell carcinoma, SRS is contraindicated. Yes, few papers are going on the studies are going on, but still in small cell lung cancer, SRS is contraindicated. So we do an MRI repeatedly every 3 monthly. So it adds a cost burden to the patient. But even if we have a new lesion, even so many patients in last 5 years, we have done second SRS also. Even one patient have just at the margin of the tumor because of our very good imaging and accessories. We can just repeat the SRS also with a very good local control, because in gamma knife, they are giving 0 margin. But in true beam with X knife, we are with our setup errors, what we have calculated initially, we are giving 2 mm, but now we are still giving 1 mm, which we can't exclude till now. So this is so in 2013-14, the NCCN started with 1 to 3 lesion. Then the ASTRO recommendation started in 2013 for having yellow guidelines for good prognosis, when to do SRS, when not to do SRS. But believe me, I find that these all are written in this, but it's a personalized and individual decision that when to give, when to not give. And it's your slowly your experience when you gain with the previous lesion, you find it that how to give, not to give, and all these lesions. So this table I usually quote is that. So this is when you are giving SRS, or sometimes they are giving SRS plus whole brain also. So in SRS and SRS plus whole brain, the median survival is same. But the brain recurrences in 1 year, it is still high. So we cannot exclude that the new recurrences beyond the local site, it may occur. So it is 76% and 47%. Yes, but the CNS mortality is 19%. And the major advantage is memory decline, that is almost half. And death in 4 months is almost half, and CNS relapse rate in 1 year certainly it occurs. So we have also seen that first patient when we did an SRS in 5 years back, and she recurred 4 years back to the another side. It was frontal, now then she recurred at cerebellum. So yes, but still 1 year back we have vacated her, and still she is disease free till now, and she is in one PHEL some good post doing the continuously using the laptop and all, and she is able to do that. So this is the beauty of SRS, but she doesn't have any financial crisis that she was going to MRI every 3 months. Cost is not an issue for her. So this factor is also very, very important. And normally we say that in brain nets, only the microscopic metastasis is only up to 1 mm. So that's why 1 to 2 mm margins are sufficient. So initially we are giving 2 mm margins because we are not confident with our setup errors. In the initial 1 to 2 hours, slowly we have gained confidence. And now we are just working 1 mm all around and 2 mm radio body. So the radiation SRS doses, how much doses you can safely give. So till now, what I explained is that the beauty is only and only having a very good MRI, and how nicely you have delineated the tumor just going up and down three-dimensionally, not only in axial planes, simultaneously you have to see the sagittal and coronal plane. Sometimes because of artifacts, because of so many things, you can miss a very small lesion. So this is very important because you are going to get a very high dose radiation. So target delineation, even in GTV is small, but please be clear, and just by changing the contrast in all the 3 sections, just try to delineate it very nicely. Then the radiation doses. So first come the RTOG 9005, and they have just defined these doses when they combine with whole brain. So why I am saying this is that any patient who is coming up who has received whole brain radiation, still having the few local site, 257 or less than 10 cc recurrences, still there is chances of whole brain, because this is a very good large data, and it's supported that after giving whole brain also, this doses, that doesn't cause any radionecrosis. So in 9005, 9508 and 0330, what they told that up to less than or equal to 2 centimeter, we can very safely give in 24 gray. When we started SRS, so initially we are little bit worried about that. We have started with 20, 22 gray, 23 gray. But after 2 to 3 years, we are very confidently giving 24 gray, and believe me, touch wood, we have not got any radionecrosis till now. That patient is coming to emergency with all these features. We have not got it. So now we are very comfortably giving 24 gray. 2.1 to 3 centimeter, it is 18 gray. 3.1 to 4 centimeter, it is 15 gray. So these are their recommendations, but I will tell you later that how you will achieve that, because you have to see that risk versus benefit ratio. Sometimes even if in 2 to 2.5 centimeter, we have given almost 20 gray, 20. Then another study by is C0300. They have just compared if the patient have not given whole brain and it is less than 2 centimeter, then you give 24. But if he has received whole brain, then 22 gray. 3 centimeter, whole brain, 18 gray, no whole brain, 20. But when this sizes was discussing, and NCCN at that initial time, they are saying 1 to 3 lesions. It was on the childhood phase, just 1 to 3 or how much. But later on, the concept of volume has come. So the size, now we are not looking after the size only for when we are sitting in the tumor board. We cannot calculate the volume, but any tumor 2.5, 3 centimeter asymptomatic, still we can consider for SRS or FSRS. Just we take it, and after that we calculate the volume. After the size, the volume concept has arisen that 1 to 4 cc, 24 gray, 4 to 10 cc, 20 to 22 gray, and 10 cc, 18 gray is available everywhere in there. And If the tumor is larger than 10 cc, then we have to fractionate it. Whether 8 to 10 gray in 3 fractions or 6 gray in 4 fractions, like 24 in 3, 27 in 3, or 30 in 3. But if it exceeds 15 to 20 cc, then we have you given even in 30 gray in 5 fractions. Like a larger volume, patient is not fit for surgery and all, then very good performance status. Even now we are using this type of 30 in 5, 27 in 3, 24 in 3, in not good performance status, not able to come to daily to the hospital. So in that cases also, with our slowly gaining our confidence, we are using those doses also. So initially they are seeing that 2 lesion, 3 lesion, 2 centimeter, 4 centimeter, 10 cc volume, not more than, then they have 3 tumors, then 5 tumors, then 7 tumors, then 10 tumors. So slowly in 2013, after that, all the revelations are going. After that, this paper came, which says that even if how many multiple tumors are there, if you have all the combining with all the volume, if the volume is within 10 cc, then it's good for going for SRS. So they have just cut down the 10 up to 10 cc. You can safely give SRS. So they have just given that less than 4 cc, 22 gray, 4 to 10 cc, 23. So even 5 to multiple brain lesions, but if the combining the whole volume, if it is within the 10 cc, you can safely use SRS. And after that, this paper term which tells us what are the predictive risk factors which you have to take into consideration for the risk of radionecrosis, because this is the only important side effect and very toxic and dangerous side effect. So they have told that if your B12, that volume receiving 12 gray to the brain minus GTE, if it is less than 10 cc, then the risk of radionecrosis is very less. So we usually try to keep the B12 up to 8, 7, even sometimes in frontal 1 or 2 small lesions, we are getting this B12 or 2 cc, 3 cc, 4 cc like that. So B12 or the SRS is a very important predictive factor. If you are not going to achieve it, then we have to just modify in our planning, conformality, gradient index and all. We have to look over that. In the same manner, there are certain guidelines for the post-op SRS contouring guidelines. And also in that, we are giving radiation to the surgical bed and we are trying to achieve our PET of more than 48 gray. So in this cases also, we normally usually give 13.5, but 27 in 3 is also an adequate. But there are certain other papers also, they are saying they are defining SRS single fraction depending on the volume of the cavity and all. And in that cases also 1 mm margins we are doing. So salvage radiation after recurrences. So there are so many data, even we have at our centers very nicely have done 3 SRS in few of the patients and still touch wood, we have achieved a very good local control without any toxicity. And yes, after whole brain, as I have shown in 9005, they have given all after the whole brain. So after the whole brain, still SRS you can safely give, but your all other parameters should be reached. And one important thing I have missed here, the slide I think missed is that whatever I am telling about V12, that is SRS, but in 2022 UK consensus guidelines, they have published a new parameters for if your B20 is less than 20 cc for 3 fractions and B20 should be less than 24 cc for 5 fractions. So it has just recently published. So these are the parameters they have defined after so many SRS after a very long follow-up. If you are able to achieve that, then go ahead, otherwise try to fractionate it more. And as I said, WBRT is also. So just I combine a few 2 lines in that. So for brain max, SRS or FSRS is very, very safe. If you are starting with that, first start with the initials, with the small doses, then slightly go ahead and you will get a very good result. Ma'am, shall I continue, ma'am? Hello. Sir, am I audible?
Yes, you are.
Yes, ma'am, you're perfectly audible, ma'am.
Continue. Shall I continue now, ma'am?
Yes, sure.
So second case, second part is AV malformation. So we are very frequently getting AV malformation. So what is AV malformation? So it is an abnormal type of vessels complex connection between the arteries and the veins. So this is a bunch of arteries, some abnormal type of blood vessels that develop a connection between the arteries and veins, and they are deficient in muscularis layer. So the drainage vein gets dilated, tortuous due to high velocity of blood flow through fistula. So this is AV malformation. Our neurosurgeons very, very frequently we are getting these type of cases. So what are the symptoms? These are important points. Just I am highlighting is that hemorrhage, seizure, headache. Hemorrhage mostly deep-seated or sometimes it presents with seizure with an annual risk of hemorrhage. So in AV malformation, CT angiography, you find that there is a bag of worm appearance. So we have to do a CT angiography for that. But DSA is the MRI also we do, in which the T2 sequence we find it. But DSA is the gold standard for AV malformation. So this is very important point is at the initial diagnosis, we are doing DSA. But after treatment or follow-up, we are just using MRI for follow-up. And after 3 years of SRS, we are just doing a DSA. So this two important points, I just want to very, very clear it because sometimes it creates confusion that DSA we use at the initial time of diagnosis. But after the SRS, we are doing monthly, 6 monthly MRI for the follow-up. And after 3 years, we are repeating a DSA. I will discuss. So in AV malformations, these are the important points while sitting in the tumor board you have to keep in mind, like the number of AVM, location of AVM, whether it is eloquent or non-eloquent AVR. This is the deciding factor for surgery, embolization, or versus radiation. Whether it is a parenchymal or dural. What is the size of AVM? Because like we have seen that in brain mets, the volume in CC determines the doses. In AVM also, the CC volume determines the mode of treatment. So these are the 5 points which we have to look after and sit with the radiologists, sit with the neurosurgeons, and with the intervention radiologists. So we are discussing these. We have an interventional radiologist. So feeding arteries. How many feeding arteries? The number, draining veins, their number, associated aneurysm and location. This is very, very important that whether your aneurysm is perineedal, intraneedus, or how it is. So because if it is intraneedus, then whatever you are doing, it's fine. But perineedus, you have to take care of that. I will discuss that. So the associated aneurysm and location is important. Is there any clot? What is the size of the needles? What blood degradation product? Edema, thrombosis, venous ectasia, superficial or deep draining vein. Because if there is a draining vein, how much you are giving and how much it is controlling it, that is very important. Aneurysm and clips, whether the surgeon has given it clips or not. Compact needles or diffuse needles, early draining vein versus not early. So this is Pedro Mazen AVM grading scale. So this grading scale, the neurosurgeons or interventional radiologists, they frequently use to decide their treatment modalities. They consider the size, they have taken in centimeter because it is very old and very initially very long time they are using this. So what is the size, location, eloquent or non-eloquent, or deep venous drainage, whether it is present and not present, and we just divided 1 to 5 score. So they have just defined the shape of the aneurysm AVM like it is cryptic, occult, micro, small, moderate, and large depending on the size of that. So as I have discussed in the brain mets also, we have to always consider the factors which we have to do, and you have to very confidently and smartly say, no, I will not do in this case. This is the smartness in SRS. So our primary aim is always and always to prevent bleeding by complete obliteration of the meatus. So this is our primary aim. So how SRS and radiation work? It just does the end arthritis. It just obliterates the end arthritis of the endovascular layer. So this is the mechanism of action. So we have to consider the factor, age, medical condition, previous bleed, prior procedure, volume and location of the AVM, and the present symptom. If the patient is very sick, unable to lie down, because you have to consider the time during the CT planning, mask making, as well as the treatment, because this type of SRS technique, we have to achieve a very, very high level of conformality. So we have to use multiple non-co-planar beams, multiple planning. So patients should be able to lie down for 30 minutes, 30 to 40 minutes on the couch. So these are the grading system. Like we have said that size, where eloquent or non-eloquent area, as we have discussed, and the deep venous drainage. So these three factors, they have 1, 2, 3, so 1 to 5. So if obviously if it is 1 or 2, then we are in a safe side like that. So we have to see whether the AVM is ruptured or unruptured. If it is unruptured, then he is blessed with God. So if it is unruptured, even 1, 2, 3, and asymptomatic, even we can observe also, or we can go for SRS. But if it is symptomatic, then SRS or plus minus embolization still in grade 2 and grade 3, 1, 2, 3 we do. But if it is grade 4 and 5, then we have to do some active interventions either in SRS or embolization like that. But if the AVM is ruptured and it is 1 or 2, not 3, they have not included like in unruptured 3, 1 or 2, you can safely give SRS or microsurgery is also an option in ruptured AVM. So now the data is coming. Even if the ruptured AVM and it is sitting in the eloquent area, SRS we can safely do after the stabilization of the patient. Yes, but in grade 3 also they are having SRS plus surgery or embolization, but grade 4 and 5, if it is large volume, there is also a concept of staged SRS in AVM, means part-wise we will treat, or we will treat after sometimes like that, or embolization. So this is our IRSA guidelines, what it says. So they have decided small versus large volume. Small is less than 10 cc and large is more than 10 cc. So if there is any asymptomatic, you have always an option of observation. But in symptomatic brain wets, if it is a very small volume and there is a lobar location, yes, craniotomy and resection is the preference. I agree. Unless patient is having a severe medical comorbidities, unable to operate. Otherwise, in symptomatic lobar location, AVM always and always the craniotomy and resection is there, and after residual we have to do a given SRS. But as it is deep located, in spite small volume, we can go for radiosurgery. And again, if there is a residual after sometimes, we have a secondary SRS chances are also there. But if there is a large volume lobar location, they are saying because it is very, very large. So they are not doing surgery in very, very large. Either we go ahead with embolization, wait for some time, then do surgery, or radiosurgery in 1 or 2 stages in large lobar location. But yes, if it is a deep located, then radiosurgery is the only option. And this, it has given that patient's choice. If patients still want radiosurgery, we have to give both options, then we can give it. Now, I will take only 5 to 7 minutes to finish this point. So, in AVM, it is very simple. The neurosurgeons say that it is AVM, we have to just treat it and all that. So what are the important factors you have to be considered in that? This is very, very important, that these few points you must know it, that it is either you use at an adjuvant to previous embolization or previous surgery. But even after patient has underwent surgery or embolization, but you should achieve a stable neurological improvement after this procedure. Before that, never do SRS. And if there is intracranial hemorrhage, deep lobar location, deep-seated eloquent area, at least wait for 2 weeks, 4 weeks to resolve the hemorrhage to achieve a stable neurological improvement. And AVM needles should not be compressed by clot at the time of radiosurgery. So this is a few important points about the aneurysm. This is AV malformation. I am talking about aneurysm associated with AVM. These points you also have to look after that, because this is also some important factors to consider. Like if the patients with proximal unsecured aneurysm, if there is aneurysm proximal to the aneurysm, AVM, then there is a post-radiosurgical hemorrhage. So just be clear about that, what it is like that. If it is immediately proximal to AVM, you will give SRS, it will obliterate. So this is, if it is far away from AVM, then it will not disappear because the SRS having only 1 mm margin. If we are not counting intraneedle aneurysm, then there is very intraneedle aneurysm, very less risk of bleeding. But if they have more than 1 arterial branch proximal to AVM, then we have to just use endovascular embolization or surgery for that. Never do SRS in these cases, because it should never be obliterated with SRS. And this is the very important point, that never try to. So many concepts are there. There is always a fight in the conference that to give embolization, then give radiation. Even if any patient received embolization, don't treat immediately. Just wait for some time to settle it down, then do the SRS. And yes, we normally don't prefer embolization unless until contraindicated. But these are the 3 points we especially need embolization. That is AVM with perinidal aneurysm. If the aneurysm is just around the nidus, then SRS don't work. Only work on nidus. But what about the perinidal aneurysm? If there is dural AV fistula, whatever the radiation you are giving, whatever the nidus is obliterated, still fistula is there in blood. So SRS don't work. So try to embolize it first. And AVM associated aneurysm, there is bleed from the aneurysm. If the aneurysm is bleeding, still SRS is safely given. But if the aneurysm is bleeding, it will deteriorate the patient. So these are the few points that we have to discuss. The option of the treatment, procedure, it is a benign, and we have to counsel the patient that it will take years to obliterate. So you have to keep patients not after 3 months or 6 months of MRI, just to check us that what you did, there is no response. And still after SRS, there is chance of bleeding, and the probability of, but the success rate is almost 50 to 95%, but this success rate is at the end of 3 years, and we have to follow up with sequential imaging, as I said, that MRI, and still there is risk of seizure in cortical lobar AVM, so continue with anti-epileptics, and repeat SRS also has an option after 3 years of surgery. And she should avoid the pregnancy till 3 years, because it might be having a very high risk of rupture even in the 3 years, as well as during pregnancy, due to hormonal changes, there is a risk of bleeding. So there is a risk of hemorrhage and bleeding from the AVM. So as we have discussed that these factors you have to consider, and these are the target delineation, and these are the IRSA guidelines depending on the volume, how much doses, like same like a brain mets. Like if the lesion is located in motor cortex and brainstem, then you have to decrease the dose. But yes, if the volume is more than 15 cc, then you have to do a staged SRS after 3 to 6 months. Like we have to delineate certain half of the volume treated right now. And after 6 months, second SRS we can do after 3 to 6 months. And normally 16 grade is the safe surgery. Repeat radiosurgery, yes, we do after 3 years if there is any residual is there. And this is the imaging fusion. I'm just skipping it all. So these are the side effects. Like radionecrosis is the most important risk, because headache, nausea, vomiting. And I assure you, because in the last 5 years, I have not found any patient headache, nausea, vomiting like that. And even one point I missed it, that we are still now in the fear of edema. We are giving steroids 4 milligram like that. But in West, I have discussed with so many centers, and some Gamma they have to came for our classes also. They are not giving the steroids, because most of the lung patients, they have to start the immunotherapy, and they are saying without using steroid, there is no edema, no headache, nothing like that. And hemorrhage is still the risk during the latency period, 2.5%. So as I said that in pregnancy, there is a risk. And the patient of AVM during the 3 years, he should not use a very strenuous exercises like forced breath holding, grunting, or roller coasting, upside down yoga, hanging upside, or gymnastic like this, because there is still the risk. And this is the most important slide. I again repeat that we are doing the DSA for investigation, but MRI for 6 monthly follow-up for 3 years, and it will take a gradual obliteration. You have to assure the patient that it will take 3 years minimum to 7 years for complete obliteration. Yes, but it will just stop the growth and further side effect or related complications like that. And if the MRI for 3 years showed complete closure of the AVM lesions, then we do a DSA. So after 3 years, it shows a complete closure, then DSA. But if before 3 years, it says, if anyone done MRI, if in MRI we are saying that there is gradual response, then at 3 years we repeat the DSA. But in MRI, in 3 years, we suggest that there is a leaders obliteration. There is complete at 15, at 1 year, 2 year, there is complete obliteration of leaders. But still, we will wait for 3 years to repeat an DSA. We will not jump up the DSA in 2 years, 2.5 years. And if after 3 years we demonstrate that AVM leaders is not obliterated, there is always the risk, always the chance of re-SRS. I think, ma'am, it's so much time, so many other slides are still there. So shall we take it for other classes, because it will be too heavy for the...
That doctor will decide. Muted.
Dr. Rashmi, you have given a very nice talk on this SRS, and you have covered almost every corner for the malignant metastasis and non-malignant AV malformation and all. I think it's nearly 1 hour.
Yes, sir.
And, so we must
But
conclude.
people won't concentrate.
Because this is for the radiation oncologist itself, and it's a good topic, very good delineation of target. But one thing I want to ask, whole brain RT, if a person is having multiple mets, more than 3 to 5 or so, with less than 2 centimeter or 1 centimeter, as usually we see in metastatic setup. Can we combine whole brain RT with the SRS?
Sir, I just want to give you a very beautiful example. In the last 1.5 years, what we have found that we have tried that 8, 10 small max 1.5 or 2 centimeter. Even I can show you the MRI pictures of our patient, because otherwise I have not added it because it will be heavy loaded. So 5, 10, 7 max we have irradiated last year. The patient is working in some media and very well preserved, 42 years metastatic CLR. So we have done 2 times. Last year, 7, 8 max, we have given 27 in 3. This time again 4, 7 max, we have again given 2 months back 27 in 3 only. And just I want to add in that, in spite of using the whole brain, what we find it from the last 1 year, she is doing well. But another person also, another patient, metastatic breast, he thought that the whole brain we can do it, but she told that I am unable to come, only 2-3 fractions you completed. And she came after 1 year to us and telling that few new lesions are there. His son was telling, ma'am, just do the same procedure. So just it's a small point, but in spite of using the whole brain, yes, I agree. If the patient has financial constraint and all that, whole brain RT itself also gives a very good result. I don't disagree with it. But what we do in our center, sir, if there is multiple brain mets, then we just do a simultaneous integrated boost. We give the whole brain radiation plus the residual lesion. If they are big, then 40 in 10, if 36 in 10, and if they are little small, then 42.5. We have calculated the BED, which Dr. A.K. Anand has taught us in 2013. So we have still now made the chart of that, and we found that what sir has told us.
Dr. Anand, 2013, he must have been in RGCI or with the Max 2013.
Sir, in 2013 he was at Max. So I am fortunate to work with him, and slowly at that time the SRS was just evolving. So we have learned from him. But this method, whole brain with 42.7, they are not giving 30 here. So sir is giving 31.2 in 12 fraction, 42.7 in 12 fraction, and 40 in 12 fraction. So I found that patient in 12 fractions, little bit better, very good local control. And since 2013, even if the whole brain with SIP, we are just doing an IARC till since 2013.
Good.
So this is the beauty what we learned with.
Can I ask one question?
Yes, ma'am.
What's the difference between the survival rates between these two? Like external.
We are not discussing at this time the survival rate or we are just focusing achieving the neurocognitive function restoration, as well as giving the whole brain. I have seen the patient that 6 to 8 months patient general condition is not going to be very good. Little bit deterioration is there. So I have clearly said that if the patient has no financial constraint, he is able to have a regular follow-up.
Is it also covered under Ayushman?
No.
Sir, ma'am, no, ma'am. I just tell you very honestly that we are saying the SRS, but even if we are doing this in IMRT package also, we are not restricting, because if we are able to find that patient is going to benefit with that, so we are doing in IMRT package also. We are not restricted, because as I know with Dr. Anand that this is our learning process and something different. So we have not taken the cost into consideration for doing that. Like DIBH, left-sided breast, what we are doing, even if in 3D CRT 1.5 lakhs we are doing, because we just feel something good, and our physics team is very robust team. And we do because, and we learned all this during COVID time, which we have less issue. So we have defined very robust protocols. So what they are asking is what you did in COVID. So I just expand and just make my protocol for SRS for our department. So I did in COVID.
Good.
Very good.
Good, very nice.
Congratulations for that. Just one more thing.
Yes, ma'am.
Anything more proton therapy would add to it?
Ma'am, I will say now that proton is a costly therapy. Very few indications, certain is like pediatric tumors sitting near the brain, eye and brain like that, or spinal cord like that.
Okay,
But
for very
everyone is saying gamma knife. We are just doing everything with X knife in spite of cyber knife, in spite all these things. But one thing I want to say that proton is not good for SRS if the lesion is less than 1 centimeter. But we can do SRS with cyber knife in less than 1 centimeter. Dr. Jalani himself tell us.
So you think the best type of radiation therapy for brain mets or primary brain tumor is stereotactic? You mean to say that? Or gamma knife or linac?
Well, gamma knife is now obsolete. They are not all centers, they are closing the gamma knife. Few centers just they are bringing. But yes, proton is in investigational phase. Yes, it is coming. Chennai, then Tata is making.
We are not sure about the protons, no? Only one or two centers are there in India.
Dosimetry is still in the learning phase, ma'am. But these are
tried and tested नहीं है. Tried and tested नहीं है proton
It will take time. It will take time.
बट मैम जैसे डॉक्टर आनंद बताते हैं कि जब 99 में जब IMRT आया तो सारे लोग कहते थे ये जो है क्या प्राइवेट वाले पैसे लेने के लिए कर रहे हैं, ये कर रहे हैं, वो कर रहे हैं. अब सारी चीजें वही, अब ये सब लोग
वही पहुंच रही है.
तो आज हम प्रोटॉन के लिए जो बोल रहे हैं शायद 10 साल के बाद कहें नहीं प्रोटॉन ही अच्छा है. तो टाइम विल टेल.
Naturally, time will tell. Where is Dr. Anand? Still with us?
No, ma'am. No, sir. He left 1.5 years back. Now he is at Fortis FMRI, Gurgaon.
Gurgaon. That's why he did not come. That's why he did not come in conference. He was not there.
That's right.
So, thank you very much, Dr. Rashmi.
I have learned so many things from Dr. Anand, sir. I am blessed to work with him. Yes, sir.
Yeah.
So, very nice lecture and very nice, simple and easy way to explain SRS. Very nice. Thank you.
Thank you,
Thank
sir.
you for your
So rest of the topic like trigeminal neuralgia, acoustic schwannoma like this, we will cover in the next 10-15 days.
10-15
Yes,
days.
sure, because we have treated
We'll call you back
certain
again.
patients.
You are a very
Schwannoma.
good teacher.
Thank you,
for your
Thank you.
thank you for your elaborative, informative, and very, 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 very enlightening talk. Thank you, Rashmi, so much. And we welcome you again for another talk. So, good night for the day.
Good night, ma'am. Good night.
Bye.
Bhaiya.
Thank you so much. So with all your permission, we are concluding the session over here. Hello. We are concluding the session over here. Okay, sir.
Thank you. Thank you.
Thank you. Thank you. Thank you.